Welcome to the Dogtor Bros, where we have an honest discussion around vet life in and out of the clinic. My name is Adam, and I am your doc of the day. I am a relief veterinarian, working in Louisville, Kentucky, and as always, I'm joined by some of my friends from vet school.
Hey, this is Brandon. I'm a veterinarian living in Fort Collins, Colorado, with practice limited to internal medicine.
Hey, this is Jeff. I am a dermatology associate veterinarian out of Louisville, Kentucky.
And again, this is Adam. And on today's episode, we're going to kind of be going through kind of a case breakdown of a specific disease process that all of us see, and that is Cushing's disease. Before we get into that, though, we'll start with a little opening question, one that's just a little bit to get to know us that I don't think we've touched on before, but just kind of a general question here. Where did you grow up? And did that affect who you have become?
This is Brandon. Yeah, I think where I grew up affected who I've grown to be, as many things do in our lives. So I grew up in a variety of places. My early childhood, where I'm not really a toddler or anything anymore, maybe 3-4 years old, is when we were living in the Virgin Islands. And that's where my mom's from, and my mom's whole side of the family. We lived in St. Thomas until I was 9. And then when I was 9, we moved to Georgia, and I lived the rest of my childhood there. And I think both of those places shaped me. The Virgin Islands is a very special place to me, and I try and visit when I can. Fortunately, I was able to go just this past summer. It had been a little while. And yeah, I think the culture of that area, the Caribbean in general, let alone St. Thomas, shaped me in a way. And then living in the Southeast definitely shaped me too. I'm living out in Colorado now, and culturally it's very different, and I like it out here too. My wife and I have both kind of lived all over the place, and it's definitely shaped us to who we are. I think the last little bit for me is I've moved around a couple of different places, and I still have places that feel like home, but my wife and I are very comfortable kind of making wherever we are home. And that's a big thing that shaped me moving forward. Yeah, I don't feel like these stainless steel strings keeping me tied to Georgia or St. Thomas or anything else. I feel like we can kind of make wherever we want to be home, and Colorado is where we really love to be right now. So we're happy to be here.
And this is Jeff. I grew up, technically I was born in North Carolina, which I don't talk about a lot because we moved out when I was pretty young. I actually was born in a very not awesome area. Well, I'll rephrase. I'll say the general area was, I think, a little bit lower income. And then I know that my parents wanted us to have more opportunities. And so we ended up eventually moving to Texas for a couple of years outside of Dallas. And then I spent most of my childhood in Atlanta, and in northern Atlanta specifically, and a suburb. And it was a little bit more of a quote unquote, I guess, middle class area. And I think that did have a huge impact on a lot of the opportunities that I've had and been able to do. And then I went to University of Georgia. So I think all of that shaped who I am, and lo and behold, now I'm somehow in the same city as Adam in Louisville, Kentucky, which if you had asked me when I was a kid, where do you want to end up? And buying a house in Louisville, Kentucky would not have been on my bingo card, but here we are.
And lastly, this is Adam. I was born in a suburb of Chicago, Illinois. We did not live there long. In terms of after I was born, we moved back to Kentucky. I say back to Kentucky because that's where my parents were originally from. When I was about 3 years old. So not a ton of memories from Chicago area. I do have little bits and pieces of memories from there. The biggest thing that I think I brought with me from Chicago was their sports. I'm a big Chicago Bears fan, big Cubs fan as well. So still repping the Chicago sports teams. I do like the city there. I've been back to Chicago a couple times. I do really like it. It's a really nice city. We moved to Owensboro, Kentucky, which is for Kentucky, I guess I would consider it a big town. It's not a city, but kind of a big town feel. So kind of a balance between big town, again, not city, but bigger than the more rural areas of Kentucky you think of, and lived there throughout all my childhood until I ended up going to undergrad and then down to Alabama for vet school, and then ended up in Louisville, which I think Louisville for me at this point is a really good balance because it has, it is a bigger city, but it does have a small town feel to it, in my opinion. Again, we're a little bit further out from the city, so that helps as well. But yeah, as all of us say here, where we came from and our stops along the way have really made us the people that we are. So wouldn't change it for anything. So looking ahead to this episode, again, we're going to be kind of deep diving into Cushing's disease or hyperadrenocorticism. And I find it really interesting when we were talking about what to do or how to do this episode. It's really cool that we can do this with both a dermatologist and an internal med specialist because we kind of have two separate sides of the same disease, and that we can kind of focus on and get kind of two different specialty opinions and points of view on one specific disease, which is kind of a cool tactic that we can do here. So just to start us off, so for people who don't know, who may not be in the vet field, Cushing's disease or hyperadrenocorticism most commonly manifest as a hypersecretion of the adrenocortical hormones. Chronically increased circulating glucocorticoids can be caused by long-term glucocorticoid administration, which is iatrogenic, or it can be naturally occurring caused by excessive endogenous cortisol production. And the clinical condition associated with chronic cortisol excess is often referred to as Cushing's syndrome. So to dive in a little bit, when you guys get a case and you're looking at it for the first time and you start to think, okay, Cushing's disease is towards the top of my list of differentials for this specific case. What are you guys seeing? What specifically from a dermatologist side and from an internal medicine side are you looking for to point towards this might be a case of Cushing's?
So from dermatology side, and this is interesting because there have been a couple of papers, large scale retrospectives, including one that one of my resident mates is actually in the process of publishing. She just submitted her abstract or presented her abstract at our last meeting this summer. But there's a significant subset of cases that present having their dermatologic signs first. And so those are often the ones that will come to me because they like to present as like random example, 5-year-old female spayed lab that has these large widespread crusts, or often people will quote like endocrine alopecia. So sometimes it's bilateral. I don't always strictly go by that rule, but I like to see lots of hair loss. Sometimes they'll have these recurrent infections on the skin that a referral doctor maybe just has not figured out like what is the underlying trigger to. They typically start off as non-pruritic cases that eventually may become pruritic with a secondary infection. So that is sometimes why they might present with crusts or papules. And so I'm always hunting for, if a case presents to me like that and they really don't have any signs of itching, I like specifically if the owner can tell me like, oh, they've never had any skin problems before. This has all kind of happened really gradually over the past however long, whether it be months, sometimes years. And then we may get into some diagnostics and things, but like I kind of want, that's like I would say the classic history for me to start hunting. And then my brain automatically immediately rules out, for the most part, anything allergic. And I start looking for what are non-allergic things that cause hair loss And then infections kind of come about, which is related to the hormones, specifically in this case, cortisol being overproduced and then causing immunosuppression of the skin to get those recurrent infections.
And this is Brandon. For me, it's a variety of things. Sometimes, like I get referred a lot of different things, for like primary liver problems, or for primary urinary problems, or for blood pressure elevations. So those are all different things that can be affected, or different systems that can be affected by Cushing's. And I'd say probably the most common one is liver enzymes being elevated. There's a pretty classic like liver enzyme elevation that you should look for. That's ALP, with ALT sometimes being elevated. And normally it's like really high, like it can be as high as a couple thousand. And sometimes it's less than that. And depending on, what the other history is, or what the other history that we get from the client, it starts to click pretty fast. So normally they'll come in for like elevated liver enzymes, let's say. And then the dog comes in, it's panting really heavy, which is another classic sign of Cushing's. It's got a dull hair coat, which is another sign that I know Jeff sees more. And then you get to talking to them, and sometimes you just have to get like a good history. Like it kind of goes back to just getting a really good history. You're like, okay, this Cushing's is on my list. It fits really well with what I'm seeing already. Hey, like, does your dog seem to be eating more than normal, which is another sign of Cushing's? Hey, does your dog seem to be drinking and peeing more than normal? And like you start to kind of get a narrow picture of like, okay, like this is most likely what we're dealing with. We need to focus our work up here. And that's oftentimes what happens. And then sometimes you have them where they come in and they're like, they have all that stuff and the owner's already seeing it. They've already Googled and they're like, yeah, I think this is it. I'm like, yeah, me too. And we just need to do the test. So yeah, that's typically what I'm seeing.
Yeah. And I'd say based on what you guys are seeing in GP, when I see Cushing's cases, it may be slightly more so with the IM kind of signs. So we'll see them come in. They may have like the pot belly. They may be panting hard. They may have the increased drinking, increased urination, those sorts of things. And then we run some blood work. We'll see that high alk phos, and then that kind of prompts us to be like, all right, well, maybe we should run a test to assess for Cushing's. Sometimes they'll have like the patchy hair coat, that sort of thing as well, in terms of the derm side. I will say that some of those do present 4 signs associated with Cushing. So sometimes they'll be like, they're panting nonstop and now their belly looks swollen and they're drinking all the time and peeing all the time to where they weren't before. And then sometimes it's kind of more of like an incidental finding, like the tech's getting the history. They're like, are they drinking more than normal, peeing more than normal? And the owner hadn't even realized it, but they're like, well, now that you mention it, yeah, past couple of weeks, past couple of months, they have been drinking more and peeing more and panting more and doing these things. So it can be one of those things where sometimes clients can catch on, but I feel like some of the clinical signs associated with can be kind of subtle or sneaky as well, to where it's not always clear cut that the client catches that. So again, just like Brandon said, that's where getting that history really comes into play and is of importance. Now, in terms of diagnostics for Cushing's, I know there's a couple of different tests you can run, a couple of different things you can do. What is both of your general approach? Do you have like a standard you'd like to go to, or is it kind of case dependent on what test you like to run? What's your typical protocol when testing for Cushing's?
This is Jeff. I'm most definitely going to go first before Brandon bulldozes me with medicine. Things that are really important to me. And I also want to point out, like when I look for histories, I do classically ask for those PU, PD, PP. I want to know the polyuria. Are you peeing too much or excessively, eating too much, drinking too much? The polyuria, polydipsia, polyphagia, PU, PD, PP are really helpful, but we don't always see them initially. But it's very case dependent, which can make these cases really hard, Adam. And one thing I also want to point out before I forget is these cases can be tricky because there are some that will initially present with allergy, which just is a nuance and makes things complicated, but a good thing to keep on your radar if it seems like, as an example, they have these chronic recurrent infections that aren't really going away with classic allergy management that you feel like has been worked up, or the allergy seems really mild, are also cases where I'll say, diagnostic wise, I usually will start with like a CBC Chem, and I always do a full thyroid with mine personally, because a lot of cases that present in derm world that start with those recurrent infections, when the case started off being non-puritic or not very itchy, when I think of endocrine world, a lot of times the cutaneous signs of a dull hair coat, recurrent infection without any obvious underlying cause, can also fit perfectly with a thyroid case. And those clinical signs can be really vague, especially if the owner doesn't really notice PU, PD, PP signs. So I generally will run that whole thing. I want to see full CBC chemistry. I'm looking for soft screen, maybe a little bit of cholesterol can be elevated, but most of the time, and I'm certain Brandon will go into more detail, most of the time I look at that ALP as like a very soft screen, and then I want my thyroid to be pretty much normal or boring, as far as my free T4 by equilibrium dialysis, TSH, because those diseases can overlap in their presentation. So if the alpha is elevated, I agree with Brandon. Most of them can be in the thousands, but I've seen one where the upper range is 131 for the alphos ALP, and I caught a Cushing's that was 135. So it was very slightly elevated. So I do also try to encourage even our students, and if I talk to general practitioners over the phone, I say, hey, if the alphos is elevated and everything else kind of fits with the case, you can still consider testing for Cushing's if there's no other obvious underlying cause, because you might catch it. And then, I would say my only other ad for specifically testing for Cushing's, I'll be super brief. I do stems. 99% of the time I do it. The 1 hour ACTH stem is my first line test.
I think that's good. This is Brandon. Just out of curiosity, Jeff, when you do your thyroid testing, are you doing like a full thyroid panel, or are you doing like just a T4?
No, I always want a full thyroid with a free T4 by equilibrium dialysis, TSH. Total T4 is always on there. But one thing that's very, I don't know if it's controversial, but I know on a lot of routine bloods, when I worked in GP, like there's that panel that's like CBC Chem with just the total thyroid, but there are so many cases that I catch that have normal total T4s that it's, in my opinion, it needs to fall out of favor. Like I just want the whole thing.
No, I love that. I think that's important. So the reason I bring it up is just like there's some data that like 40 to 60% of dogs with Cushing's have a low total thyroid hormone, and you need that TSH, that hormone that like stimulates the thyroid gland. If that measurement is normal, then you can just kind of like take hypothyroidism off the table. So I like that you're doing the full panel, and I think that's really important. So yeah, I mean, like your like initial workup is my initial workup, and oftentimes as specialty like doctors, we are already getting previous like workups that have been done from primary vets. So a lot of times, like I've already got blood work from like a complete blood count and serum chemistry and potentially urinalysis. You know, I potentially already have things like we have a really strong mobile radiology group that does ultrasound. So sometimes my patients come there and have already had an ultrasound. So I think the big things are like for diagnostics, looking at your CBC and chem, are the classic signs there for the CBC? Platelets typically really high. For the chemistry, you're looking at your ALP. Obviously, sometimes their glucose will be a little higher than normal. Sometimes the electrolytes will be a little wonky for a couple of different reasons. I won't go into detail. And then the urinalysis should be really dilute urine. Should be like less than a like 1020 specific gravity. If it's more than that, like if it's more than like 1030, it's unlikely to be Cushing. So you can kind of start taking it like lower on your list, but not off your list. Sometimes they'll have glucose in the urine, and then oftentimes they'll have protein in the urine. And those are all pretty classic signs. We could go into way more detail on just those things, but I will hold
Yield.
back. But the big things are, there's two big tests, or I guess there's three tests. The really simple one is a urine test. You can get a urine cortisol to creatinine ratio. That's like a really basic screening test. You want to be careful because if you take a pet to the vet, collect the urine sample there, they're already stressed out, so their cortisol is going to be high, and it's going to come back as a positive where it might not have been positive otherwise. But if you have a client that's like, I don't want to do these big tests, and I'll say why in a minute, and we wanted to just do a basic screen, you can say, okay, go home, wait like 5 days, collect a urine sample, send it back to us, and we'll send this out. And if it's like if the urine cortisol to creatinine ratio is like essentially negative and below the threshold, I'm very confident that Cushing's is not the problem. But the two big tests that we all know, Jeff mentioned one, the ACTH stimulation test, or essentially stimulating the adrenal glands to pump out cortisol. And depending on whether or not they have Cushing's, it may or may not be elevated. I say may or may not because these tests aren't perfect. And sometimes we get results that are negative when these patients actually have Cushing's, and we have to figure out like, what can we do next? The other one that we do often would be like the next step is a low dose dexamethasone suppression test to kind of suppress the adrenal glands from producing cortisol. And if they produce more when they're getting a steroid from outside the body, then it would be abnormal. And we have cutoffs for that too. And you may even be able to differentiate between the two types of Cushing's, which would be like abnormal production directly from the adrenal gland or abnormal stimulation from the pituitary gland in the brain. So those would be like my big initial tests, just to put like feelers out for the other like stuff that we don't normally do, but you could do. If you feel pretty confident that it's not an adrenal mass, usually that's by doing an ultrasound and you don't see a big adrenal mass on one of the adrenals. You could do things like an MRI and look for a pituitary mass. They're not easy to see, so it might not be present. We don't often like measure ACTH, the hormone that stimulates the adrenal glands, but there is some research going into that, and that might be something that could be looked at, or could be done in certain cases, but we don't really often do that. And then potentially like CT scan, but those are all of the head to look for a pituitary mass. But those are pretty. There's some pretty specific scenarios where that would happen, and I can touch on that later.
Yeah, I was actually going to follow up with Brandon on this because, like Brandon said, the two big ones that you hear about are the ACTH stimulation test and the low dose dex suppression test. Early on in my career, I was mostly running ACTH stim test, but I have since transitioned to where now for my initial screening test, I run low dose dex test. I've watched some CE and done some research a little bit on this, and it seems that I've seen, and I can get the internist opinion on this as well, is that it's recommended of the two. What I've seen is it's more so recommended to start with the low dose dex suppression test as your first line of screening, unless you're testing a diabetic patient, and then the ACTH stim test is preferred. That's just what I've seen. So I was interested to get your opinion on that, Brandon.
As far as like the specific to diabetes stuff, I don't know off the top of my head. I will say, as far as just like sensitivities versus specificity, without going into detail on what that is, basically, the better the sensitivity, the better you can trust your negative result, and then the better the specificity, the better you can trust your positive result. So for like low dose dex, sensitivity is 85 to 100%, depending on what study you look at, which is pretty good. And then the problem is the specificity is like 44 to 73%. So that's why we don't like testing dogs that don't have the classic signs, because sometimes it'll come up positive, even though they're not really positive. Like you got to test when you the test is appropriate. And then for the ACTH stimulation test, the sensitivity is around like 80 to 83%. So if you get a negative, you're only 80 to 83% confident that that negative is true. And I've had that happen, unfortunately. And as far as specificity, it is like 100% specific. So like if you get a positive, great, you're good. For like convenience, the tricky thing is like the ACTH stimulation test is, you draw a sample, you give them the gonadotropin to stimulate the adrenal gland, and then you measure in an hour, you draw another sample. So it's, it requires a little bit more time, but it's relatively straightforward. The low-dose dex is a whole day affair. Like you got to get them in there in the morning, you draw a sample, you give them the dexamethasone, and then you got to draw blood at 4 hours afterwards and 8 hours afterwards. And like, it's a whole ordeal. So if like I have a patient and I'm really suspicious and they're, they got there at like 10 o'clock, and I offer the client, I'm like, hey, we can do this. These tests aren't perfect, but this is like quick and dirty and we can get it done essentially. And if it's positive, great, we move forward. If it's not, we're going to have to do this one. And that's usually how I present it. But I'll have to look into the like diabetic specific stuff. Maybe I can find it while we're still talking here.
Yeah. And this is Jeff. And I wanted to point out, like, Adam, your way is perfectly fine. If I always joke about this sometimes with colleagues or clients or students, it's like, if you want to get a group of internists and a group of dermatologists to fight over one thing, ask them like which one of these tests they would do first and explain themselves. like it is literally people get so heated about which one to do first and why. And at the end of the day, there's no perfect test, which is why there's constant arguments. And every time, I swear to God, every time I go to a CE, the answer on which one to do first has changed. And we get more data, there's more information, there's more things you can do, there's more nuances. I am an ACTH stimmer primarily as a first line for multiple reasons. Number one, if it's a straightforward Cushing's case, then I'm pretty comfortable working it up, treating it, and getting them in good control. But if it becomes like, if my stim is not stimming like I want, it's coming back like pretty unconclusive, then we start talking about I could do a low dose dex, but it's that time length in the day that really gets me, because the way our schedule works is like they would have to drop off almost a little bit early and be here all the way until pretty much closing. And so it's not super practical. We've done it and I have done it, but to me, I'm like, I go for the convenience. And that's also part of how I was trained, is that this is the 85% solution. Like it is good enough. It's very reasonable. And we know the next step if it happens to not work out, which I imagine, Adam, like you're in a slightly different scenario, which is there's a lot of these cases that aren't going to be referred and then you got to work them up. So it's kind of like, you pick the one that makes the most sense and you move forward, and both are appropriate, because if one isn't giving you the answer, then you do the other one.
Like you guys said, there's no perfect test. You get what works best for you. And as long as you're doing your due diligence, you're, figuring out what's best for you and for the patient, and, what's going to be the best option, then, you're doing what you need to do and you're doing it right, as long as you're doing it by the patient, for the patient, and by the patient. I had one patient, because again, like I said, most of these I do like to do the low dose dex suppression test. I had one client that I spoke to, and their dog got super anxious coming to the vet, was super dog reactive and dog aggressive, and they just did not feel comfortable leaving their dog at the clinic for 8 hours. And I'm like, look, hey, I get it. We have this other test. We can run it in an hour. It's still not ideal, but a lot better than 8 hours. And so for that specific case, we ran the ACTH stim. So being adaptive, doing what's best for your patient, best for your client, and best for you to try and figure out what's going on. I mean, you're really not going to go wrong with either of these tests, because at the end of the day, it's like you guys said, no test is perfect, but we do what we can to get the result that we need to get.
We hope that you are enjoying this discussion on Cushing's disease. This concludes part 1 of this discussion. To catch part 2, head back next week where we further discuss the management of Cushing's disease.
Thank you once again for joining us on the Dogtor Bros.
If you would like to support us, please share this episode with others who may be interested in today's topic, and leave us a 5-star review on Apple Podcasts, Spotify, or wherever you listen to your podcasts.
Would you like to influence our next episode? We love hearing your opinions and thoughts. Your comments may be our next topic.
Please leave us suggestions via email at thedoctorbros@gmail.com, DM us at the Dr. Bros on Instagram, or leave us comments on our posts. Again, this is Brandon. You can reach me at Dr. Mason IM on Instagram.
And this is Chris, and you can reach me on Instagram at dr.chrishernandez.
And this is Jeff. You can find me on TikTok or Instagram at DermDrJeff, DermDogtorJeff.
And this is Adam. You can reach me on Instagram at DrAdamDVM. That's DrAdamDVM.